Okay, let's dive in. Today we're taking a deep dive into a specific condition, and we're guided by a set of revision notes you've shared with us.
That's right.
Our source material focuses entirely on Strongyloides Stercoralis.
Yep, that's the one.
Think of this as your high-yield shortcut, really, to understanding this parasite and, well, the disease it causes,
Yeah,
perfect for revision or just getting quickly up to speed.
exactly.
Our mission is to break down these notes, pulling out the essential facts about, its definition, how you get it, who's most at risk,
Uh-huh.
what it does inside the body, what symptoms it causes, how we find it, how we treat it, and the potential problems.
And we'll definitely be highlighting the really critical bits from these notes, the things that explain why this particular infection is, well, so important to understand, especially for certain patient groups.
All right, let's unpack this then. What exactly is Strongyloides stercoralis? How do the notes define it?
Okay, so at its core, it's a parasitic nematode. That's a roundworm. You might also hear it called threadworm, especially when talking about the larva. And the notes, they identify its primary target in humans as the intestines.
Okay, the gut. And the condition it causes, what's that called?
That's strongyloidiasis. And the notes point out it can be acute, but really importantly, it can also be chronic, sometimes just hanging around silently for years.
Silent for years. Okay, that already feels like something to remember. To help with the name Strongyloides stercoralis, I kind of picture stercoralis linked to soil, because that's where it lives, and gut, because that's where it mainly ends up. Does that trap?
That's actually a neat way to connect it. Yeah, it lives freely in the soil, but then becomes parasitic inside us.
So that brings us to how people actually, get this worm. What's the cause? The etiology.
Well, it's pretty straightforward environmental exposure. The source is contaminated soil.
Contaminated soil. And how does the worm get from that soil into a person?
The notes specify that infection happens through direct contact with that soil, like skin contact.
Direct contact. Okay, that points us towards who might be more likely to get it. What are the key risk factors the notes highlight?
Well, a major one is just location, living in or traveling to areas where it's common, particularly, tropical and subtropical regions where sanitation might be poor.
Okay, so geography and sanitation, big drivers. What else increases the risk?
Direct skin contact with that soil, as I said, often just walking barefoot. But here's a really, really critical risk factor the notes emphasize.
Okay.
Having a weakened immune system.
Oh.
So conditions like HIV/AIDS, or someone's had an organ transplant, or maybe they're using immunosuppressive medications, especially corticosteroids, that makes someone much more vulnerable. And also people whose jobs involve a lot of soil contact, like in agriculture or mining, they're also at higher risk.
That link between weakened immunity and risk feels absolutely vital, especially when you mention that silent chronic state. It really makes you think. If someone comes from a region where strongyloids is common and they're about to start, say, corticosteroids, based on these notes, what parasitic infection should just leap out at you for screening?
Absolutely.
That combination of risk factors plus potential immunosuppression seems like a major red flag, right?
Exactly. That exact scenario is a major clinical concern for strongyloidiasis because, well, parasite's behavior changes dramatically when the immune system is suppressed.
Okay, how does it change? This is where it gets really interesting. How does this tiny worm get from the soil into us and then cause problems? Let's talk about its journey, the pathophysiology and life cycle described in the notes.
Yeah, it has a fascinating and quite complex life cycle. The notes detail how the larvae, which are the infective stage, actually penetrate the skin. That's the entry point.
Through the skin.
From there, they embark on this, well, incredible migration. Via the bloodstream, they travel first to the lungs.
Wait, the lungs? That's surprising. I'd sort of expected to head straight for the gut.
Yeah.
What happens when they reach the lungs?
Yeah, it's a key step. They mature a bit there, then they migrate up the bronchial tree, get coughed up and swallowed.
Oh.
And then they finally make their way to the intestines. In the intestines, they mature into adult worms, mostly female, actually, which can reproduce asexually, and they lay eggs.
So skin, stream, dot, lungs, swallowed, then gut. Got it. What happens after the eggs are laid?
So the eggs hatch into larvae right there within the intestine. Now, here's the part the notes emphasize is really critical and, well, unique about this parasite. Some of these larvae can reinfect the host without ever leaving the body.
Hold on. It can reinfect itself inside you. How does that even work?
Exactly. It's called autoinfection. So instead of being passed out in the stool, some larvae penetrate the intestinal wall or sometimes the skin around the anus, and they just restart that whole migratory cycle, bloodstream, lungs, back to the gut. This autoinfection loop is absolutely key. It explains why chronic infections can last for decades, literally decades. And crucially, it explains how you can suddenly get that severe picture hyperinfection syndrome, particularly in immunocompromised individuals.
Right.
The life cycle also involves free-living stages in the soil, kind of completing the picture between the human host and the environment.
Wow. That autoinfection loop really changes everything. It's not just a one-time infection you clear. You can just keep going, potentially indefinitely, unless you treat it. So the path is skin, stream, lungs, swallowed, guts, egg, seg. Then this autoinfection loop back to the stream, trying to burn that sequence into my brain.
That pathway, yeah, that captures the essential steps the notes describe, and that autoinfection step is definitely the most clinically significant twist in its story.
All right, so if someone presents with symptoms that might be strongyloidiasis, what else needs to be on the list? What are the main things we need to, differentiate it from, according to the notes?
Well, the notes recommend considering other parasitic worm infections. They specifically mention hookworm and whipworm,
Okay.
which can have similar GI symptoms, and are also soil-transmitted helminths. That's the broader term for parasitic worms. And you also need to think about non-parasitic causes of gastrointestinal symptoms because the presentation can be quite general, quite vague sometimes.
Makes sense. Where in the world is this most prevalent? Let's look at the epidemiology the notes describe.
It's significantly more common in tropical and subtropical regions globally. The notes point out it's, less frequent in places like the UK.
Right.
And cases seen there are usually imported, as they say, through travel or migration from areas where it's endemic.
Do the notes give a sense of the scale worldwide? How many people?
Yes, they do. The global prevalence is estimated at a pretty substantial 100 million people.
100 million. Wow.
Yeah. And the notes highlight areas with moist soil and inadequate waste disposal as having particularly high prevalence. They list examples like West Africa, the Caribbean, Southeast Asia, Brazil, and even parts of Spain.
100 million people. That's a huge number.
Yeah.
Okay, let's talk about what this infection actually looks like in a person. What are the clinical signs and symptoms described in the notes?
Well, the common symptoms are kind of typical GI complaints: abdominal pain, diarrhea, maybe nausea, vomiting, weight loss, that kind of thing.
Okay.
But the notes also describe symptoms outside the gut, which, makes sense given that migration path we just talked about.
The lungs again?
Yeah, exactly. Cough and shortness of breath because it passes through the lungs, and also skin rashes.
Any specific types of skin rashes mentioned?
Yes, the notes mention papulovesicular lesions. Those are sort of small bumps or blisters, and an urticarial rash, which is like itchy hives. They also specifically note that passage through the lungs can cause pneumonitis, which is inflammation of the lung tissue itself.
Right.
And it's important to remember these symptoms can be vague, often nonspecific, especially in chronic infection. But the notes contain a really critical warning.
Okay.
In immunosuppressed patients, you can get disseminated strongyloidiasis, and this can be fatal.
Fatal. That sounds like the severe end you mentioned earlier. Is that the same thing as hyperinfection syndrome?
Yes, essentially. Hyperinfection syndrome is part of that severe disseminated picture. The notes describe this as a massive increase in the worm burden,
Okay.
leading to severe complications like lung hemorrhage or the larvae penetrating organs way outside the usual gut-lung pathway, and secondary bacterial infections piling on top. And this is strongly linked to immunosuppression. That's why the source material emphasizes the absolute necessity of excluding strongyloids before starting immunosuppressive treatment in anyone considered at risk.
That really drives home the importance of that risk factor.
Yeah.
So putting it together, imagine a patient who needs to start long-term steroids. They've done it with maybe a vague rash, a bit of a cough, and they mention recent travel to Southeast Asia. Based on these notes, what infection is suddenly right at the top of your suspicion list, and why is it so urgent to investigate? This scenario perfectly illustrates that danger, right? Activating a silent infection with immunosuppression.
Exactly. That constellation, the travel history to an endemic area, those non-specific symptoms like rash and cough that could relate to migration, and then the impending immunosuppression.
Yeah.
It points strongly towards needing to rule out strongyloids urgently because of that risk of hyperinfection.
So if we suspect strongyloids, how do we actually diagnose it? What investigations do the notes recommend?
Okay, so the gold standard mentioned is examining stool samples to actually find the larvae or eggs.
Right.
However, the notes do caution that finding them can be difficult, especially in chronic low-level infections. You might need serial samples, over several days.
Okay, so stool tests can be tricky. Are there blood tests that help?
Yes, a complete blood count, or CBC, is useful because you often see eosinophilia.
Using a
Yeah, that's an increase in eosinophils, a type of white blood cell. It's commonly associated with parasitic infections, and you see it particularly in the acute and chronic stages of strongyloidiasis. But the definitive diagnosis, it really hinges on finding the larvae themselves. Specifically, the rhabdutiform larvae, that's the non-infective stage, usually found in stool.
Okay.
And sometimes the filariform larvae, which is the infective stage, might be found in stool or sometimes in duodenal fluid. That's fluid collected via a tube passed down into the small intestine.
Duodenal fluid, right.
Yeah.
Are there other ways to test, maybe looking for the body's response? Like antibodies?
Yes, antibody detection using enzyme immunoassay or EIA is recommended, especially when looking for the larvae in stool or that duodenal fluid hasn't been conclusive. It's a pretty good screening test.
Right. Well, I sense a but.
Well, yeah, the notes do include a warning. These antibody tests can sometimes cross-react with other nematode infections, so you could potentially get a false positive. And if the patient has lung symptoms, a chest X-ray or CXR can help detect complications like infiltrates cloudy areas or consolidation or even cavitations, which are like holes in the lung tissue.
Okay, trying to keep track of those tests. Maybe a mnemonic like CellLab. S for stool, L for larvae ID, A for antibodies, and B for blood, like the CBC and eosinophilia.
That's actually a pretty concise way to remember the main diagnostic approaches mentioned. Yeah, SLab works.
Yep.
And it's key to recall, as the notes emphasize, that serology, the antibody test, can't tell you if the infection is active right now or just a past exposure.
Right.
But monitoring antibody levels can be helpful to see if treatment worked in someone who's immunocompetent, because the levels should ideally fall after successful treatment.
Got it. So once diagnosed, how do we treat strongyloids based on these notes? What's the recommended management?
Okay, treatment. The primary approach involves antiparasitic medications. The notes list ivermectin or albendazole as the main options.
Right. Is treatment necessary for everyone who tests positive, even if they have, like, 0 symptoms?
Yes, absolutely. The notes are really explicit about this. Treatment is required for all patients.
All patients.
All patients. And this goes right back to that critical autoinfection life cycle we talked about. And that risk, that future risk of developing potentially fatal hyperinfection syndrome later on, especially if they become immunosuppressed for some reason down the line.
Ah, okay. So treating the silent chronic infection basically eliminates that future danger.
Precisely.
What are the specific doses and durations mentioned for those drugs? Ivermectin and albendazole?
Yep. For ivermectin, the recommended dose is 200 micrograms per kilogram daily for 2 days.
Yeah.
And the notes cite a high eradication rate with that, around 97%.
2 days. Good.
For albendazole, it's 400 milligrams twice daily for 3 days. And the notes mention it can be repeated if necessary.
3 days for albendazole. And what about that uncomfortable itching rash you mentioned earlier?
Yeah, symptomatic treatment is also part of management,
Yeah.
specifically using antihistamines for the pruritus, the itching, and of course, for those really severe cases, particularly disseminated infection in immunocompromised patients, the notes indicate that hospitalization and often intensive care are needed. It's serious.
Okay. To help remember the drugs and duration, maybe think ivermectin or albendazole.
Right.
I and A are neighbors in the alphabet.
Mm-hmm.
Ivermectin is shorter, 2 days. Albendazole is a bit longer, 3 days.
That works. Those details are certainly high yield for anyone, preparing for exams or just needing that quick recall.
What's the outlook for someone with this infection? What does the prognosis look like according to the notes?
Generally, with appropriate antiparasitic treatment, the prognosis is good. The notes are quite clear on that point. For uncomplicated cases, things usually resolve well. However, there's always a however with this one. They strongly reiterate that severe or disseminated infections, particularly in immunocompromised individuals, carry a significant risk and can indeed be life-threatening.
Still a serious threat in that group.
Definitely. And prevention is also part of the picture described, emphasizing good sanitation and simply wearing appropriate footwear in endemic areas to avoid that initial skin contact with contaminated soil.
Makes sense. You mentioned severe forms and disseminated infection. What are the specific complications listed in the notes that we should be aware of?
The main and most dangerous complication is that hyperinfection syndrome we've mentioned a few times. It's sometimes called disseminated strongyloidiasis when it spreads widely beyond the gut and lungs.
Okay.
And this can lead to larvae invading multiple organs throughout the body. It causes very serious systemic issues like sepsis,
Right.
which is that life-threatening response to infection, meningitis, severe pneumonia, significant gastrointestinal bleeding. It can get really bad. And again, the notes consistently highlight that these severe complications are far more common and pose the gravest threat in immunocompromised individuals. It
Yeah.
just keeps coming back to that critical connection.
So what does this all mean then? Wrapping this up, we've taken a deep dive into these notes on Strongyloides Stercoralis, covering the key facts from how you get it to how you treat it. The absolute core takeaways, it seems, from these notes revolve around its really unique life cycle, particularly that autoinfection capability and the profound, potentially fatal risk this poses when a patient becomes immunosuppressed.
Exactly. Understanding that silent chronicity and the mechanism of autoinfection, well, it explains why treating everyone is just non-negotiable. And recognizing the link between a weakened immune system and the devastating possibility of hyperinfection or disseminated disease is probably the most critical clinical insight from this material.
Yeah, it's a powerful reminder, isn't it? That infections acquired maybe years ago in one part of the world can suddenly become acutely dangerous if a person's immune status changes later on.
Absolutely.
Knowing the risk factors, the clinical signs, even the vague ones, and that critical need to screen before starting immunosuppression. They're just vital steps for preventing these really severe outcomes.
And maybe here's a provocative thought for you, building on what we've discussed. How might a seemingly unrelated event, like someone needing treatment for, say, an autoimmune disease or a cancer that requires steroids, how could that suddenly unmask a life-threatening parasitic infection they've carried silently for maybe decades? How does that potential change how we take medical histories and screen patients, especially those with relevant travel or exposure history?
That's a really important question to consider. This deep dive was based entirely on the revision notes you provided, hopefully helping you cut through the noise and focus on the high-yield facts and those critical insights.
Yeah, hopefully useful. And for further preparation and resources designed specifically to support learners like you, do check out passthemsra.com and freemissra.com.
Definitely explore those resources. And join us next time for another deep dive into the information you bring to the table.